maintain response to treatment in different chemotherapies.
Thank you so much for this opportunity. Greetings from Bangalore, India. Serum thyroglobulin measurements after surgery is used to monitor patients to identify those with persistent disease, recurrent disease, and those with disease progression. And this systematic review, recently published by Julie and Suzanne et al., found that a level more than 10 was with a median sensitivity of 71 and a specificity of 78%. Now, what about post-operative thyroglobulin, which is very high to indicate distant metastasis? We have one good paper which suggests that the post-operative stimulated thyroglobulin in treating distant metastasis was optimal cutoff around 61.87 with an extremely high area under the curve. But now we have moved away from residual disease, recurrent disease, and we now have ATA dynamic risk stratification. So how does this pre-ablative, post-operative stimulated thyroglobulin correlate with this ATA dynamic risk stratification? This paper from the nuclear medicine team in China, where 98% PTCs who all underwent radioactive iodine ablation, a pre-stimulated TG value of 14.9, seem to predict those who have structural residual disease compared to those who do not have structural residual disease, which is your biochemical incomplete, your indeterminate, and your excellent response. The odds ratio of around 3 to 5, depending on the cutoff of 10 or 14. Similar nuclear medicine paper, again, PTCs predominantly all underwent radioactive iodine therapy. Again, a value of 22.45 seem to get those who are having structural residual disease. And this paper in the JCNM, again, predominantly looking at PTCs who all underwent central neck and or lateral leg dissection and all received radioactive iodine therapy. They found a cutoff of 26.75 as a cutoff of their pre-ablative stimulated thyroglobulin to predict structural residual disease on follow-up. But the ATA recommendations has two issues. One, it gives you in the ATA high risk, it tells you that serum thyroglobulin, where is suggestive of metastasis, is high risk, but they don't give you a value. So the aim of our study is to find a pre-ablative stimulated thyroglobulin with ATA response therapy, sort of mimicking what has been done already, but in a more heterogeneous cohort. And second important question, among those who have structural residual disease, can your pre-ablative stimulated thyroglobulin actually decide who are going to need additional therapy, which means another dose of iodine, external beam radiation, chemotherapy, or surgery, versus those who have the structural residual disease who are just going to be quiet and may not require much intervention. So this was a retrospective study of medical records of patients with thyroid cancer followed up in the endocrine clinic, tertiary care center, 2016 to 2023. All patients who underwent thyroid surgery or revision surgery at our institute or elsewhere and came to us for risk stratification and management. All patients subjected to thyroxine withdrawal and stimulated thyroglobulin and anti-thyroglobulin antibodies and whole body iodine scan 4 to 12 weeks after the surgery. Ultrasound neck performed at our office once in every 3 to 6 months. And radio iodine ablation decided by a multidisciplinary team and chosen who gets it and who doesn't get it. Inclusion criteria, patients should have completed at least 12 to 18 months of follow-up, and data should be available for us to assess the ATA response therapy. We exclude people with hemithyroidectomies, anaplastic thyroid cancers, incomplete surgeries, or those with incomplete evaluation or data. Patients who have high anti-TG levels more than the upper limit of cutoff of our labs were excluded because they potentially influence thyroglobulin values. You all know this, the ATA response therapy. I don't want to go over the slide, but just to follow, this is what we followed in terms of defining what was an excellent response, indeterminate response, biochemical incomplete, and structural residual. If a patient did not fit into an excellent response category, they were subject to additional testings, including iodine scans, FDG PET, CT chest, or MRI brain, as indicated per the clinical basis. This was a baseline characteristic. The mean age was around 42 years, 68% were females, 87% PTCs, about 50% were in the ATA intermediate and high risk, and you can see that the central neck dissection and the upper lateral neck dissections was uniformly spread out in all the groups, and about 83% received radioactive iodine ablation. The cohort was followed up for a median follow-up of 25 months, approximately 2 years, and the testing of the stimulated TG after surgery was approximately about 32 days median after the surgery. We got about 46% who were in the excellent response. We had about 29% who were in the structural residual disease, and the remaining in the indeterminate or the biochemically incomplete response. People who got radioactive iodine therapy tended to have higher TGs as well as more likelihood of having structural residual disease, obvious with the fact that they received radioactive iodine therapy, probably they had a higher grade or higher stage disease. But when you divide the pre-ablative stimulated thyroglobulin into three categories, less than 1, 1 to 10, and more than 10, which has been done by the previous authors, we found that as the TG goes up, the proportion of patients who have structural residual disease moves from 9% to 19% to 52%. And on an odds ratio univariate analysis, the post-operative pre-ablative stimulated TG of more than 10 had quite a significant predictor of those who will have structural residual disease, and this risk factor was almost equal to other risk factors, traditional risk factors like ATA high risk, or people who have metastatic disease, or people who have PT4 disease. So this value of pre-ablative stimulated thyroglobulin after the surgery seems to give a very strong odds ratio of having structural residual disease in the future. When you do a multivariate analysis, it retained an independent risk factor for defining those who are going to develop structural residual disease compared to those who are not going to develop structural residual disease. A 5-fold risk that is statistically significant. And when you do it under the area under the curve, you saw that a pre-ablative stimulated TG more than 16 captured about 80% of people who had structural residual disease. Now the next part of the question was, among these structural residual disease, who are the ones who required intervention and who did not require intervention? The people who did not have intervention, the majority of disease was in the nodes. They had small volume, either central or lateral compartment nodes, and were just being followed up, 82%. 17% had lung nodules which are being followed up. In comparison to those who required intervention, 71% were extranodal disease, either skeletal mets, or it was a brain met, or it was a lung met which progressed in size and became symptomatic, requiring systemic therapies. If you look at the TG values of people with structural residual disease who required no intervention, 46 of them, compared to those who required intervention of 31 of them, the TGs were significantly different. I'm talking of the pre-ablative post-operative TG, and we're looking at a 2-year follow-up, dividing them into structural residual disease who are being followed up and with no intervention or intervention. So at the end of about 23 months of follow-up, you could see a clear difference of the two groups. And this is just to show the graph that the two groups, the blue bar showing the ones with structural residual disease requiring intervention, and the red one, structural residual disease not requiring intervention, they both come together closely, but they all begin at a very different place. So which means that the disease was extensive to begin with, and we are just uncovering it as we go along the curve. When we look at the best cutoff to see who are the ones who require additional therapies, we found that the ROC curve showing us a value of more than 95. So if your post-operative stimulated TG is more than 95, you have a 72% chance that you will need additional therapies rather than just surgery and radioactive iodine. So to conclude, a pre-ablative stimulated TG more than 10 independently puts the patient at a 5-fold higher risk of having structural disease at a median follow-up of 2 years. A pre-ablative stimulated TG of more than 16 will capture 80% of those who have structural residual disease, and more importantly, a value more than 95 will tell you that you are likely to have structural residual disease that requires an additional intervention. Our study has certain strengths and limitations. We have a median follow-up of 2 years or more. So most of the structural residual disease is usually apparent in 2 years, so that's a fairly good strength. TG, anti-TG assay done in the same center, same CLIA lab. All patients undergo a baseline iodine scan, so we're not missing anything which is iodine sensitive. Serial ultrasound neck performed by a single operator, so that's again a strength. It's a retrospective study, so that's going to be some bias involved in the selection of patients and the data. All patients with structural residual disease do not have a histological confirmation. If you have a suspicious lymph node, if you have a lung nodule, we don't always go in and poke and find out if they really have a cancer or not. So there are going to be patients whom we assume that this thyroglobulin is probably coming from this structural disease, but we don't have a histological proof for every single structural residual disease. Thank you, and my credits to my team who helped me do this study. Thank you very much.